Good morning, everyone. Thank you, Mr. Chairwoman, for the introduction. I am fitting in for Dr. Rasha Al-Bawardi, who is supposed to make this presentation. She is in maternal leave after giving birth to her first baby girl. I am happy to be here with you. My thanks and appreciation to the scientific and organizing committee for the generous invitation. I don't have any disclosure for this presentation. Except probably to say that we as interventional cardiologists like to be challenged with anatomy, complex anatomy, left main, bifurcation, calcium in the coronaries, to play with our toys in the cath lab. But occasionally we are challenged with the clinical decision making rather than an intervention itself. So this is a 71-year-old female patient with diabetes, dyslipidemia, hypertension, prior coronary artery disease with the PCI done in 2015 for ACS. She ended up with a stent in the LAD. Subsequently, 2021, she had instant stenosis and she had another PCI. IVUS at that time showed a moderate disease in the ostium of the left main, treated medically. The patient lives in a rural area around 600 kilometers away from our center. Fast forward to March 2023, she presented again with chest pain, new onset 4 days prior to presentation, weekly positive troponin and non-specific ECG changes. She was diagnosed as non-STEMI. Her lab investigation showed fairly controlled hemoglobin A1C and LDL cholesterol, normal renal function. Her hemoglobin was 12.3, echo showed normal ejection fraction, mild LVH and mild mitral regurgitation. She was admitted under cardiology in the cardiology ward with a diagnosis of non-STEMI, received the loading with dual antiplatelet therapy and heparin and for cath next day. So she was taken to the cath lab, and the angiogram, as you can see, shows significant ostial left main disease with the positive remodeling of the shaft of the left main disease. She had instant stenosis in the mid stents with the mild disease in the right coronary artery. So IVUS was done. Unfortunately, I couldn't show the IVUS. The movie is not working. I apologize for that. But it's confirmed that she has significant ostial left main disease. So now it's a dilemma for the operator. She has an NSTEMI, normal ejection fraction, ostial left main, ISR in the LAD, low syntax score of 18, diabetes. She's a stable hemodynamic. So little brainy here is thinking which option should he proceed with. Should he go with ad hoc BCI for the left main, or should he just wait and run this patient through the heart team meeting? So who would go ahead and perform BCI in this patient? By show of hands. Ostial left main, stable. Maybe two. Okay. So you're not completely wrong. There are evidence from registry data. This is from a registry data from New York area. Showed up to 11.67% of patients with left main disease, they go for ad hoc BCI. Operators choose to go for ad hoc BCI. It included patients with diabetes and low ejection fraction. An accompanying editorial on the same issue showed in registry data showed up to 55% of patients would go for ad hoc BCI. Ostial left main disease is a spectrum of disease. Not all left main diseases are the same. Ostial disease is different than shaft disease, different than the distal bifurcation diseases. The outcome for PCI is similar in the ostial disease is similar to CABG, yet those patients will go for more revascularization when compared to CABG, and distal disease, they would have a catch-up phenomena in the future. This was shown in multiple registry data. Many of us would proceed with ad hoc BCI in an unstable patient who refuses CABG, or patient with a poor protoplasm. But we always would run those patients through the heart team meeting, which we did in this patient. So we waited for next morning. We obtained a consultation for our cardiac surgeon colleagues. The patient had massive lower GI bleeding. She dropped her hemoglobin from 12.3 to 8.7 over 3 days. We stabilized the patient with blood transfusion. We stopped her Plavix and stopped her heparin. We obtained gastric consultation which, with upper and lower GI endoscopy, showed sigmoid colon cancer with a locally invasive tumor. Workup by oncology showed no metastasis. So the aim of the surgical team is to go for cure in this patient. So little brain here is thinking, how should we proceed with this patient? Should we just send her for surgery, perform PCI? Which stent should we use? What kind of DAPT we should use? Weighing the balance between bleeding and stent thrombosis, and what is the best timing for the non-cardiac surgery? Guidelines really does not answer this question, but it clearly tells us that left main patients are completely different than the rest of those patients, and they should go for revascularization. Guidelines tells us we should take this condition by case. But for patients who go for revascularization, then achieving complete revascularization in those patients is very important, and they should have their procedure after 6 weeks from their intervention, because if they have it within 6 weeks, there is a 19% increase in preoperative mortality and MACE. So she was declined CABG, and the team favored PCI. We'd like to use risk score to risk stratify those patients before we commit them to DAB. There are multiple scores out there, the precise DAB, the DAB score, the Barris score for classifying patients. Unfortunately, these scores, during the derivation of those scores, did not include patients with cancer. The other question is that one would think of using bare metal stent. We can do that, especially in patients with high bleeding risk, large coronary artery, where you're going to use the stent, patients who are non-compliant to dual antiplatelet therapy, and patients requiring recent surgery. New generation drug-eluting stents really outperforms the bare metal stents as shown in multiple trials. So what do we know about cancer and coronary artery disease? So nowadays, patients with cancer tend to live longer. Many patients they survive for a longer time, and the number one killer in those patients is actually coronary artery disease. 50% of patients with breast cancer, with prostate cancer, breast cancer, endometrial cancer, thyroid cancer would die of coronary artery disease. Those patients, they share the same risk factors as patients with coronary artery disease. What we know, during the initial presentation, many of them, they would have myocardial infarction, death, major bleeding, or target lesion revascularization. There is a plethora of articles are being published recently, and it shows the outcome of PCI in those patients. There's an increased all-cause mortality. There is an increase in the cardiovascular mortality, higher 90 days readmission days with MI and bleeding. Specifically in patients with colon cancer, they have higher rate of bleeding, and patients with lung cancer, they have higher mortality. A notable mention of those article is this paper, and where they validated the DAPT score in 4,000 patients, and they've shown that the DAPT score performs well in those patients. It can dichotomize which patient would have a higher event. There is, again, a plethora of evidence of using a shorter DAB medication and in patients with requiring shorter DAB with excellent outcome. A notable mention is the Master DAPT trial. Our colleague Mirfat Al-Asnaj was a co-investigator in this paper, and it shows that the shorter DAPT use is non-inferior to longer DAPT medication with the lower bleeding risks. There are potential multiple solutions for high-risk patient with high risk of bleeding. There is a combination of multiple DAPTs or SAPTs styles and duration one can choose from. The European guidelines was instrumental in providing a way to treat those patients. Patients who require a time-sensitive non-cardiac surgery, like our patient, she was diagnosed with sigmoid cancer with bleeding. And it shows exactly what are the steps that one should really follow. So it recommends for shorter DAB duration, 1 month, then stopping the Blavix or the ticagrelor 2 days prior to admission, bridge those patients with 2B3 inhibitors or cangrelor for 2 days during hospitalization, and then stop them 6 hours prior to the procedure, and then this patient can have the procedure safely. There are strategies that can be implemented to decrease the incidence of bleeding before the procedure, during the intervention, or after the intervention. Before the intervention, like using risk score to classify patient, using non-invasive testing, and making sure the intervention is really appropriate for patient and avoid loading those patients, use the radial axis, use weight-adjusted heparin, and use the appropriate stent for those patients, and use the best choice for the patient that can decrease the incidence of future bleeding. So we go back to our patient. So what we did. So we used a safe femoral access, ultrasound guided access. I don't remember what was the reason for us to use the femoral access. We chose, this is an IFAS-based intervention. We used a 4.0 Ultimaster third generation stent. We used a low-dose heparin. We started the patient on dual antiplatelet therapy 3 days prior to the intervention to just gauge the risk of bleeding of this patient. Procedure was uneventful. The patient went home 2 days after the procedure. We readmitted the patient after stopping her Plavix for 2 days prior to admission, bridged her with 2B3 inhibitors. She had an uneventful procedure. Then we reloaded her. And our aim is to go as long as we can with the DAPT medication since the source of the bleeding was sorted out. The patient did very well. We brought this patient at a later day to fix her mid-LAD disease with a drug-coated balloon. We did an IFAS, showed well-opposed stent, and she's doing very well. So, Mr. Chairman, ladies and gentlemen, in conclusion, many cancer surviving patients died due to coronary artery disease. There is an emerging literature in cancer and coronary artery disease. Multidisciplinary approach is advisable in high-risk bleeding patients with active cancer. There are multiple DAPT and SAPT combination and styles and duration, which must be carefully balanced for each individual patient, and the treatment should be individualized. Thank you.
Thank you, Dr. Saad.